Okay, welcome to our second part of our abdominal imaging. Today we are talking about contrast studies. So in gastrointestinal fluoroscopy we have two series of studies. We have upper gastrointestinal series and lower gastrointestinal series. In the upper we have a barium swallow, barium meal, a small bowel follow through, where we want to see the esophagus, stomach, and small intestine. In the lower GI, we have barium enema and air contrast barium enema, just to watch the colon and rectum. So these are a few indications for different type of studies. So today we have a barium swallow or barium meal. So the indication should be swallow diffusion, dysphagia, hiatal hernia, reflux, gastro-duodenal pain, anastomosis, patency. Also, we have main indication in barium follow-through and barium enema. When you're going to see to start to see this request or indication from next year in your clinical phase. So let's go to remember very fast the anatomy. So this is a barium meal. So you can see the stomach and duodenum. With the barium swallow, you can see the full esophagus here. Then this in your left is the barium enema. So you can see the whole colon, the second ascending colon, hepatic flexure, transverse colon, splenic flexure, descending colon, sigmoid, and rectum. And on your right, you can see the double contrast barium enema. So let's go to pass and talk about terminology. What is very important when we talk about contrast studies and fluoroscopy in specific? We have to know the terminology. You're going to see frequently during your life as a doctor. No matter from which specialty you are, you always have to be leading with radiologists. Okay, so you just try to pay attention. So we have in terminology for basic description. We have a filling defect, ulceration, diverticulum, and stricture. Well, repeat, filling defect, ulceration, diverticulum, and stricture. Remember, you can pause the video. You can pause the video, and you can rewind again and hear the the recorder again. Okay, it's very important for you. Pause the video and study. So let's go to start with filling defect. Filling defect we have two types: intraluminal lesion and extraluminal lesion. So intraluminal lesion is a lesion inside the bowel lumen, totally surrounded by barium. Majority of the cases is equal to cancer. The extraluminal lesion is very uncommon, but anyway arise from outside and compress the bowel, cause narrowing from one side only, and forms a shallow angle with the bowel wall. Anyway, we will be focused in intraluminal lesion just for your level. So in this request, you can see this esophagus. Okay, so remember our first esophagus so was complete. The one there is a filling defect. That means there is something inside of the esophagus, which is which is made the which is made the barium to know cover completely the esophagus. Okay, so for that reason you can see this filling defect just in your left side. Talking about the esophagus, also we have another in your right, the stomach. Okay, you can see this huge filling defect. It's very important for you to know that. It's always filling defect. The majority of the cases are cancer. This terminology is very difficult to understand at the first sight. to understand on the first side. We will posting more videos so you can understand better all these kind of the diseases and the radiology terminologies. I know it's very difficult. So this is another thing. The thing on your left, it is a cancer of the anthus of the stomach. See the huge filling defect over there, which is marked already, and then there's another filling defect in the jejunum. Okay, you can see this huge filling defect, which is marked with the arrow. So we go to the ileum, and then now you can see there is another filling defect. You see there is something inside which is made impossible for the barium to cover that area. At the end of this presentation, I have some graphics, some draft you can, and give you another point of view so you can understand better the kind of abnormalities. So this is a sample of extrinsic esophageal compression, okay, from outside. But you see, it's very difficult to know that in this case we're in the presence of fibrosis or lung fibrosis, second to tuberculosis of the lung. Now the second filling defect is the strictures. So the stricture you have two characteristics. They are tapering end and abrupt with overhanging edge. So abrupt tapering end and abrupt with overhanging edge. So these are sample strictures. In your first left, you have a chronic reflux esophagitis can produce this kind of strictures. You see a focal stricture. Then the second picture we have achalasia, which is common I think common disease. You want to see a lot of them. You want to see a lot of them, so you have to review achalasia very well. There are different grades. You want to see more in surgery about that, talk more about surgery about that, but you have to look at the achalasia very well, okay? And this in your right, the caustic stricture. This is a patient from Ghana. So I will say young boy, the young boy is about 7 or 8 years. He's from North Rio. They come to us with this with a history of having swallowed a caustic substance, so can produce all this kind of stricture, all this kind of pathology. Okay, he was very lucky because he's alive. Then another type of stricture is Crohn's disease. Crohn's disease is also it's not too common, but you want to see a lot of patients with Crohn's diseases. Okay, with Crohn's disease, maybe 1 to a year with Crohn's disease. Sometimes it's misdiagnosed, but so the reason you have to pay attention. Always you have to think in Crohn's disease. So some patients come to the OPD with abdominal pain. You are thinking in another causes. Sometimes the patient have this kind of chronic inflammation of the bowel. Another thing can produce this stricture is a mechanical obstruction, mechanical bowel obstruction, maybe from small bowel obstruction or large bowel obstruction. Okay, and then another disease can produce stricture is the chronic ulcerative colitis. Chronic ulcerative colitis. Okay, we will talk more about this in surgery because you have in surgery you have the main radiological signs for this one. All these diseases we're talking about have the specific radiological sign that is talking about is very broad about this kind of the diseases about stricture. So when you see a colon like this, you can think, okay, this is maybe chronic ulcerative colitis, where we have more radiological sign for this disease, but for now, for you, it's okay. Another type of terminology, the terminology is diverticulum. So the diverticulum is a circular out pushing connected to the bowel lumen, usually fills with barium. Okay, usually fills with barium. So let's go to start with the esophagus. So esophagus, we have diverticulum in the first part of the esophagus, then in the second part of the esophagus, and then the distal part or inferior part of the esophagus. The esophagus from the superior or first or from the inferior or the distal part of the esophagus, they are calling pulsion diverticulum. Pulsion diverticulum. Okay, pulsion diverticulum, because that means the wall of the esophagus is weak. For that reason, these diverticulums appear. But in the second part, we call it traction diverticulum. Traction diverticulum. Why? Because in general, in this part, the diverticulum is second to fibrosis. Okay, that means something is pulling the wall of the esophagus. Okay, in the majority of the cases, the fibrosis is due by tuberculosis, lung tuberculosis. So that's very important to know. Okay, or pulmonary tuberculosis. This is another type of diverticulum. This is a duodenal diverticulum. You can see here very clear with the arrow. And then you see in your right the giant sigmoid diverticulum. Okay, giant sigmoid diverticulum. This sigmoid is the same thing as a unique diverticulum and is very red as well. And then we have a diverticulitis. So diverticulitis is when you have more than 2 diverticulums. Okay, more than 2 diverticulums. We call it diverticulitis. The diverticulitis is frequent, produce inflammation and perforation, which will to lead to abscess. Okay, lead to abscess, inflammation and perforation. Okay. Now the fourth terminology says ulceration, which is an injury of the mucosa surface with formation of an ulcer crater filled with barium. Filled with barium. You can see in this picture. You can see in this picture that it's very similar to the diverticulum. It's very similar to the diverticulum. So what is the main difference between the diverticulum and the ulcer? And the ulcer is Hampton line. Hampton line. Hampton line. Hampton. Hampton line. So you have to check that out. What is Hampton line? Anyway, I've made the description after this one. Maybe upload the PDF that talking about that. It's very important. You have to know the difference between ulcer and diverticulum. Also, the difference between malignant and benign ulcer. It's very important for you to know that the difference between malignant and benign ulcer. Let's continue talking about the diverticulum. You can see here very clear all this kind of diverticulum. Okay. So now we have this draft. You can see all this in graphic. So with different pathologies. With different pathologies of the esophagus. Okay. So I'm more visible so you can get a better idea of what the disease is and how they appear. Then this esophagus with this stomach with the same thing with different kinds of diseases, so you be more reliable to diagnose the disease. And this is a small intestine with the same thing. And this is the large intestine. You can see here this is a large intestine with the different kinds of diseases. Now let's go to talk very fast about endoscopy. So the endoscopy coming from is a Greek word. So endo meaning inside and scoping meaning to see. So you have to, like you see inside or something. So this is a list of the major type of endoscopies: the gastroscopy, colonoscopy, laparoscopy, proctoscopy, and many more. Now, what is important for us in this case is the GI endoscopy, okay? GI endoscopy. In specific, the esophago-gastro-duodenoscopy, which is a more common even they're doing for emergency and that kinds of things, okay? So you can see first the request for the esophagonoscopy, and then the contraindications. You have to know very clear request and contraindication. Then you have to put it on your brain, okay? And last, to finish this orientation, conference orientation, I brought to you a problem management. So what to do in each case, in which patient come with different sign of symptoms and pathologies, okay? So in this case, you should be very careful when you in your next year. Very careful when you arrive to the OPD or the emergency room. Okay. So in case of trauma, the patient with trauma, you have to request abdominal plain film, ultrasound, and CT scan. You can see the abdominal plain film to look for skeletal lesion, pneumoperitoneum, retroperitoneal air, mass effect, and foreign body. In ultrasound, while ultrasound, also you have to request for peritoneal fusion. You have to look at the liver, spleen, kidney, or bladder, and urinary bladder lesion. In CT, also if it was a trauma, you have to look at the retroperitoneum. This is complementary to ultrasound, grievous lesions, and mesenterity. And then we have painful syndrome with fever. So in this case, when you have a painful syndrome with fever, you have to request for ultrasound, not X-ray. You can see the difference here. Trauma is X-ray, but painful syndrome we don't have it's not necessary to request X-ray. So in this case, ultrasound, so look for any type of inflammation like cholecystitis, liver abscess, kidneys diseases, ascites or splenomegaly, and CT as well is complementary to ultrasound. So just to look for the abscesses of retroperitoneum, pyelonephritis, inflammation of or digestive tract perforation, perihepatitis, site thrombosis, mesenteric infarct. So CT is always complementary to ultrasound. And then we have more than that, painful syndrome. This in case without fever, anorexia, weight loss, nausea, and emesis. We have also the management of the liver function test disturbance. Also at the upper digestive tract hemorrhage and proximal intestinal occlusion. In this case, we have many more, but just a few examples. What do you have to do in case of the kind of patients? Okay. So, like I say, I will load more material about this issue for better understanding. That was a simple orientation conference. So, thank you.